Good morning, good afternoon, good evening, and good night, friends and colleagues from around the world. Welcome to our first session today of the 2020 Peer-to-Peer Global Dental Interdisciplinary Summit, where more than 450 doctors have come together as peers to bring knowledge and education to our colleagues from the most distant places. Today we have one of our regents hosting, Dr. Joseph Mina Atala, and Dr. Charles Zahedi is our special guest from UCLA. He's a DDS PhD, he's a periodontist specialist, and has done countless projects for the professional community, from goodwill efforts to mission work to helping veterans. Just a good, kind-hearted human being that has trained and helped tens of thousands of doctors over the years since he has been in the profession. And he's very much loved by many of our colleagues. He participated in the 2018 Global Summit, our first large summit. And he's back in 2020 for a peer-to-peer operation. And we hope to have him back again in 2022 and beyond. With that said, thank you, Dr. Atala and Dr. Zahedi, for joining us today.
Thank you.
Thank you, absolutely. Thank you for your invitation.
Ladies and gentlemen, as of this morning, the numbers show us that we have exceeded 1.150 million people, 1.50 million people, and that's astonishing of what we can achieve together when we work together and we donate our time and resources to make this happen. I encourage you to stick with us. We have some very famous speakers coming up in the days to come as we conclude this summit, and most of us go back to our normal lives with the COVID and use this knowledge and information that we have obtained and gained to help hundreds of millions of patients subsequently. Again, thank you for joining us this morning. I will turn over to our moderator and host, Dr. Joseph Mina Atala. You have the floor.
Good morning, everyone. Dr. Zahedi, we're very honored to have you today.
Absolutely, thank you.
I'm going to go very quick over your background, and I'm one of the people that are very impressed and a big fan of it.
Thank you.
Dr. Zahedi is presently teaching at the Department of Periodontics, Constitutive and Regenerative Sciences at the University of California, Los Angeles, UCLA, and was also full-time associate professor at the Department of Advanced Periodontics and Implant Surgery at Loma Linda University in California from 2002 to 2004. Since 1990, Dr. Charles Zahedi has been intensively involved with treating orally handicapped patients with advanced bone loss, and especially older adults. Dr. Zahedi obtained a PhD in oral medicine with a thesis in periodontal and bone regeneration. Most of the international publications by Dr. Zahedi deal with treating older adults having advanced bone loss and needing dental implants. He has written some of the most read scientific articles on how to make implant dentistry more affordable and predictable for all the patients, including older adults. Dr. Zahedi has lectured on the treatment of older adults and the use of dental implants and trained dentists in many countries, including the United Kingdom, Sweden, France, Italy, Portugal, Belgium, Luxembourg, Poland, the Czech Republic, Lithuania, and China. In 2016, Dr. Zahedi wrote a book chapter entitled Treatment of Orally Handicapped Edentulous Older Adults Using Dental Implants for Special Care Dentistry. In 2011, Dr. Zahedi became the founder and the clinical director of Dentists for Veterans, bringing compassionate dental care to orally disabled veterans and older adults that have no covered dental benefits and whose low income is below the poverty threshold. Set by the U.S. government, his aim is to fight the oral handicap of edentulous in patients that have lost all of their upper and lower teeth by using the newest technology in implant dentistry. And I have also to mention that he's the first one to focus on simplified and rationalization in implant dentistry. Welcome to the GIS, Doctor. We're very honored to have you, and we're very happy to have you today and listen to what to your presentation.
Thank you so much for your invitation. Can I go on the full PowerPoint mode?
Yes, please.
Thank you. So, hello everybody. Good morning, good afternoon, depending on when you're watching this webinar. As was said previously, I'm honored to be part of the UCLA Department of Periodontics. And I used to be a full-time associate professor at the Department of Advanced Periodontics and Implant Surgery at Loma Linda University. And for the last couple of years, to be exact, over 18 years, I've been actively involved in training doctors. If you need to reach me, I think the best way to do is to just send me an email to charles.zahedi@gmail.com. And I'll try my best to get back to you. I was honored to be actually part of the world's top 100 doctors presented by Global Summits. Among all of these doctors, there are probably 9 of them who have worked harder than all the others, which are the regents of the Global Summits, and especially Dr. Shah, who is a personal friend. I admire what he has done for doctors, colleagues, and patients for over a decade that I know him. I don't think without his hard work and passion, this global summit would have ever been possible. And I hope that I'm able in the future to help him and other regions to bring this global summit to other parts of the world. As it says, it's a global summit. This is my school, UCLA School of Dentistry is part of UCLA system. And actually, UCLA is currently the #1 US university for the number of applicants, and is the most applied 4-year university in the nation, United States. Being that nation, we are ranked #2 in the world, in the United States, actually #2 as a research institute, #8 in the world. This is our school of dentistry, and this is some of our students. You see that we are very lucky. We have students from all around the world, and Los Angeles attracts a lot of talent. I also provide training through implantmentoring.com in Newport Beach, California. For those of you who don't know where Newport Beach, this is Newport Beach, is a coastal area, is a beautiful area, and we train doctors hands-on. It's a 3-day or 1-day course. We provide a lot of surgeries, from simple surgeries to comprehensive, complex surgeries, and it's a very fun part of my time and life to deal and share my knowledge in a very humble manner with my colleagues. And I've been in the last 5 years actively going to China, and I am very happy to be able to continue going to China and other countries, help doctors over there learn how to simplify and rationalize implant dentistry. So I hope to bring Global Summit in the near future to our colleagues in China. So the title of this presentation is Simplification and Rationalization in Implant Dentistry. If today you go on your Google, on your smartphone or computer, and you type simplify implant, or you type simplify implant dentistry or simplification of implant dentistry, probably one of the first top 1 or 2 links that you will see on Google, organic search links that you will see on Google, is this article, Simplification and Rationalization of Oral Implantology. And as you could see, I published this article back in 2001. That is 19 years ago. So you would ask yourself why a board-certified periodontist is trying so hard to simplify and rationalize oral implantology. One of the problems we had with oral implantology is that to achieve a high success rate, we had to use some dogma. Dogma is an extremely useful tool in religion, but is not extremely useful when it comes to scientific world and the concepts. So when I placed my first implant back in 1990, that is 30 years ago, of course, there was a way different world. For those of you who are older and remember, we had to wait between 3 to 6 months after placing the implants to achieve osseointegration. We had to achieve, whenever possible, by cortical anchorage. We had to place the longest possible implant, and we were trying to place implants in a strict sterile conditions. And the aim of that article, which I published 19 years ago, is to show doctors that they can achieve the same success rate but by simplifying and rationalizing oral implantology so that more doctors, general dentists, general practitioners, as we call them in the United States, can place implants. So procedural simplification in oral implantology is not synonymous to poor patient preparation. The techniques I show you and the concepts I talk to you will give you the same success rate, we achieve the same success rate as you would do with more traditional protocols. So for example, let's look together at a case that I treated many, many years ago. This patient presented to me with, some of you might recognize the type of implants in his mouth. And of course, patient was complaining of discomfort and infection. When I looked at the case and examined intraorally and also by radiographs, you can see the problems that this patient was facing, and his doctor, dentist who had treated the case didn't know how to move forward. So they, was kind of a big complication. I had to take over. And when I removed the part of the bridge, that's what I discovered. And the patient was in this situation for probably over 1.5 to 2 years. So this older patient, 75-year-old patient, had this infection in his mouth for 1.5 to 2 years, and his dentist couldn't really help him. And when I removed the other part of the bridge, of course, the situation wasn't any better, as you could see from these slides. And when I removed the implant, this is how the implants were made. So implant dentistry came a long way from, let's say, 40, 50 years ago, before the advent of osseointegration and Dr. Bronnemark's research. And, some doctors around the world still use subperiosteal implants, blade implants. And, you have to know what the success rate is and if it's really simplifying implant dentistry using this. So in these cases, what we do, we obviously remove the infected implants, the infected teeth, and we graft the area. And I try to do it step by step because sometimes patients are older. Most of my patients are older patients because my passion is geriatric dentistry. And, when you go step by step, you make the treatment a little bit easier for them. I'm not going to go into the details of the procedure because I have only 30 minutes to talk. So I try to, just show you how we handle these complicated cases, make it more simple, and preserving as much bone as we can. I'm a periodontist, so we don't extract teeth without trying to preserve as much bone as possible. Remove the old implants, we graft the area, and we wait 6 months in a traditional method. Then we do the second phase surgery. And in this case, still traditional method. As you could see, these implants that were placed many, many years ago, they were extremely difficult to place. They were right on top of the inferior alveolar nerve, and removing them has been always a tricky business. So why did we use such complex methods? It is simply because we didn't have anything better. We can't really criticize the doctors who did use these implants because back then, probably they didn't have better options. Today, we make everything more simple, more predictable, both for the surgeon and for the practitioner. And a lot of times, the practitioner, the general practitioner, is the surgeon, which is very good. And these bars, now, of course, we have locators, are easier to clean. The plaque control is a lot easier. The repair is a lot easier, and especially for an older population. And you have patients who are in a situation that is less dramatic than the one you saw, but still they have advanced bone loss, and you might need sometimes to put more implants, do more bone grafting. The healing time is as long, and the BART solution still has a lot of merit, although today we have locators and O-ball attachments. This was a brief kind of summary of how we arrive where we are at. Now, today, I think the big game changer is that we have different implant types, different surfaces, different anatomies, and different diameters. So we used to When I placed my first implants back in 1990, 30 years ago, we had the Bronnemark implants, which were great implants. The diameter was 3.75, but the surface was not rough enough. The treatment of the surface was not good enough, so we had to place very long implants, and we didn't have all the diameters that we have today. Today we have narrow diameter implants. We have mini dental implants, diameter of 1.8 to 2.2. We have small diameter implants around 3 millimeters diameter, all the way to wide implants. Diameter can go up to 8. I personally have placed implants with a diameter of 8, and I have placed a lot of implants with diameter of 1.8 to 2.2. So all of these solutions work. We have to know the indications and know our patients, know our skill set. And the use of wide implants actually has been pretty interesting, because, as you know, one of the difficulties for general practitioners who don't have, let's say, my experience, is that how do you handle the pneumatization of maxillary sinus? At the maxillary sinus region, we have two problems. One is, of course, the volume, and the other one is the density of the bone. A lot of times we have type 4 bone, according to Lake-Holman-Zorn classification of 1985. So in these cases, we have to kind of decide if we want to use a sinus graft, a sinus lift approach, lateral window, vertical approach, Summers osteotomy. We're going to use the zygomatic implants, or we're just going to use wide and short implants. For the sake of this very short presentation, if we have only 6 millimeters available, we can use short implants, which are only maybe 6 millimeter in length. They are, of course, 6, 7, 8 millimeters in diameter. And this technique has shown extremely high success rates in scientifically published articles. Of course, the other solution is as good, which is the sinus graft procedure and simultaneous implant placement or the delayed implant placement. And when you look at these cases that are now getting older, the success rate of this technique using short and wide implants is actually similar to using longer implants. In the mandible, when you have a problem like a terminal periodontal issue where you cannot save the tooth anymore, when you do the extractions, we used to place longer implants, 50 millimeters implants, and success rate very high. Not always the easiest way to treat patients. However, we had nothing available. So in these cases, we had to use longer implants, especially when we did simultaneous implant placement along with bone grafting, because we need to achieve apical stabilization. The only part of the implant which is actually native bone was the apical portion, so the implants had to be longer. And yeah, everybody has used these techniques, and they have worked very well. And now in situations where the inferior alveolar nerve is in proximity with the ridge and you don't have a lot of height, well, in these cases, you might want to use a shorter implant if you have the width. And once more, there's a lot of brands out there. As you saw in my presentation, I'm not advocating one implant brand. I'm always teaching doctors on techniques, and I let them kind of decide by themselves among 400, 500, 600 implant brands around the world, which ones are for them easier, more logical to use. Now, what really changed, I think, and simplified implant dentistry for general practitioners is the use of 3D versus the 2D imaging. Obviously, 30 years ago, when I was placing my first implants, we only had CT scans and not a cone beam CT. And as you know, the problem with the CT scans is a massive amount of ionizing radiation and the cost to purchase and the cost to operate. And now, with the advent of cone beam CT, the amount of ionizing radiation has been reduced drastically. The cost went down. Every year, I saw new companies coming on the market, offering better products, cone beam CTs at a more affordable rate. So now, finally, we are able to plan digitally our case. And I, on purpose, removed the name of the company I'm working with right now. to develop and perfection a system where doctors can simply have a co-mim seat in their office, have a digital scanner in their office, upload to the cloud the information they obtain from the patient, and they get the surgical guide, and they get osteotomy guide, surgical guide, and provisional restoration in one. So that's a big game changer for doctors who don't want to really spend 10 years, 20 years getting my kind of experience, and they want to achieve the same results without necessarily placing 20, 30,000 implants. The other topic that is really needs to be addressed when it comes to simplification and rationalization of implant dentistry is the treatment of orally handicapped edentulous older adults using dental implants. I was honored when in 2015 I was asked to write a book chapter for the Dental Clinics of North America, which was published in 2016, because as you know, the fastest growing section of the US population is older adults, patients 65 years and older, and it's the same exact problem in China, and is the same exact problem in most European countries. So most European countries, Japan, China, United States, probably Australia, there's a huge problem of older adults. And as you know, when you have a frail older adult, it's not as easy to use traditional implant dentistry than it is to use simplified methods. And I invite you to read my book chapter. Now, when you have cases for younger adults who need treatment, like this young patient who has a broken crown and has an abscess, as you see, sometimes there is not a lot of solutions to simplify, and you might not want to simplify. So simplification and rationalization has limits, and that's why I use rationalization. You have to be rational. So when you have a younger patient with a huge abscess, massive bone loss, you really want to do things step by step. And, extraction, soft tissue grafting, frenectomy, whatever you need to do to make sure atraumatic, minimally invasive extractions, preserve the bone, and go step by step. Even you have to maybe add more complexity, is the opposite of simplification. Because in this case, placing the implants immediately would not give the aesthetic result that we would achieve if we go with a stage approach. So, when you've been placing implants for 30 years, there is no such thing as one size fits all. You can't just listen to a presentation in half an hour and say, okay, CAD/CAM technology is going to solve all the problems. Every single case, I'm going to extract and place the implants. No, in this case, as you saw, there's a massive bone loss. We had to get a massive soft tissue graft from the palate. It's a free gingival graft, and let the soft tissue heal along with the hard tissue. So why did we do everything more complicated? Well, because this case is a more complicated case. That's the answer. The buccal plate was gone. Patient has a kind of a gummy smile, high smile line, and we needed to graft, and both hard tissue grafting and soft tissue grafting and waiting, and providing the patient with the provisional flipper, stay plate, or other solutions that are used, and the patient had to wait. But then the advantage is that the soft tissue and the hard tissue heal harmoniously, and you have a huge wide width of your reach, and then you can place the implants with a surgical guide at the ideal position for the ideal result. So you couldn't do that in one appointment. When you have cases of abscess, a lot of these cases, which also are cosmetically challenging, you have to go step by step. So this is the opposite of just extracting and doing everything the same day, unless you have the knowledge and experience. Knowledge and experience, you need both to handle any and all complications. The key word here, handle any and all complications. So when you have cases like this, once more, is a question of patience and going step by step. As you saw during the presentation so far, I've been placing many types of implants. Some of you have been placing implants for a long time. You've seen already 4 or 5 or 6 different implant brands so far in the presentation. So I'm not focusing so much on the brand as on the methods and results. And this case that we saw a few minutes ago, as you see, this is yet another brand. So before going too far in the presentation, I want to give a lot of time to people who are watching this presentation be able to ask questions.
Okay, doctor, let me go ahead and put you back into the stream.
Yes,
Are
I
you
see
back?
myself.
Do you have your
No,
presentation you could
I'm
share with
going
us?
now to answer questions and answers.
Very good. Okay, the Q&A.
Bar connection. We know that the bar connection is better mechanically, while ball and socket is better biologically because there's less entrapment of the food. What's your thoughts on that? When do you pick this one and when do you pick that one?
Could you, Dr. Atala, could you please repeat the question? Thank you.
Sure. I'm mentioning regarding the difference between the ball and socket versus the bar connections.
Yes.
And we know that the bar connection is better mechanically because it disperses
Yes.
the forces accordingly, while the ball and socket periodontally and biologically is better because it's easier to clean.
Yes.
What are your thoughts on that? Do you often pick and choose according to them, or you just standardize it? Do you have a
Yes.
preference in that?
You know, extremely good question. You know, back in 1990, 30 years ago, life was easy because you had one, two or three implant companies, right? You have practically no solution. So you don't have to think too much. Today in 2020, you have so many options to choose. So as we say in English, devil is in the details. So the more experience and knowledge I gain, the more specific I become by patient by patient, is a case by case.
Yes.
Personalized, exactly, that's the word, personalized. So when I do case by case, first of all, I practice in California. So in California, as you probably don't know, is the epicenter of lawsuits for doctors. There's way too many attorneys, so we get lawsuits left and right. So I teach legal aspects of dentistry. Because I teach legal aspects of dentistry, I give any and all patients any and all options. And I have them sign a document that shows that they knew one option is to do nothing. And I tell them that's a very good option, to do nothing. Even if they have an infection, I tell them one option is not to get the treatment, all the way to the most comprehensive, less affordable option. So when you come to the world of locators and O-balls were a game changer. When you have good density bone, it probably doesn't matter if you use locators, O-balls, or bar. When you have soft bone, it starts to matter, because as you know, splinting of implants is extremely important when you have very soft bone. Now, I deal with older patients mostly. I have younger patients too, but I deal with a lot of older patients. And sometimes when you place the implants in the maxilla, the bone is like a sponge. So sometimes you can take 6 months, 3 months for the bone to heal, depending on the implant, on the bone type. Sometimes you want to load. So if you want to do immediate loading of the implants, obviously splinting is a better option. And ovals and locators and standalone solutions do not offer the splinting. So again, in 30 minutes, I tried to keep my presentation to 30 minutes because that was what Dr. Shaw asked me, and I did 28 minutes of presentation. A presentation of 2 years, when people go to 3 years of training, you can teach more. When I teach advanced periodontics, of course, you have more time. But to answer your question in a very precise manner, you have to be patient specific. So bone type, immediate placement versus delayed placement, and of course, what's your superstructure. If you use an overdenture and your upper overdenture has a big surface area, the intaglio surface of your denture is very broad. The intaglio surface of your denture provides a lot of resistance against occlusal forces. If you use the same technique but using the mandible, of course, the surface area is a lot less, especially in older adults who practically have no bone left. So you have to be careful what you use.
Very thorough answer. Thank you.
Welcome.
With the new shorter wider implants in general.
Yes.
Do you think with the new designs that we should be expecting in the future are wider threads, even though the implant is thinner, to get the best of both worlds, having good friction, yet at the same time, good amount of volume and tissue volume around the implant?
So, in the last, let's say, 30 years, I've been reading a lot of scientific articles on the implant thread design, the importance of implant thread design versus the surface technology. So the first question that we have to answer, which one is more important? Okay, I'm gonna say it in a very, let's say, negative way. Imagine you have the worst thread design in the world, which doesn't exist anymore. All implants have decent thread designs. Because I'm not a paid consultant of an implant company, I'm not going to advocate, oh, this implant is better than the other one. Absolutely not. But imagine in my world, in my opinion, there are practically no implants left on the market that have bad designs because people won't use them.
Yeah.
Okay, so it's a natural selection. So practically every implant that is sold on the market, irrespective of the country that it's made from or the price point, how much you pay for the implant, they have decent implant architecture and macroscopically. And macroscopically, when you look at the SEM, electron microscopy, they have some kind of a rough surface. Right now, the success rate we're talking about these days is not 50% success rate versus 90% success rate. These days, we're talking 89.9 to 99.9.
Yes.
Like there is no implant system that's going to fail 50%. That's gone. Nobody does that anymore. I don't know one single country in the world where a doctor will have half of his implants fail and still buying from the same implant company. They just don't. So your question is a very difficult question because in my hands, doesn't matter what implant brand are used, they have over a 90% success rate, which in dentistry, all the procedures, prosthodontics, orthodontics, endodontics, you just add all, has the highest success rate of any discipline in dentistry. Plus, what it really matters for patients doesn't matter for us. For patients, what matters is that once they get their implants, they never have cavities anymore, decay, caries, never. They never have root canal problems on those implants, ever. So doesn't matter what implant you use, it's going to be better than not placing the implant. Last but not least, what we don't tell our patients enough is that the second you put that endosteus titanium implant in the jawbone, it will start stimulating the bone. So you preserve the precious jawbone. even if you don't load the implant. You don't even have to load the implant. It just keeps the bone there. And we know it in like maxillary sinus. We place an implant on one side and we do a bilateral sinus graft. So with, both sides got a sinus graft. On one side, we place implants, the other side, we don't. Patient doesn't come back. 5 years later, on the side that were implants with no crowns, the bone is still there. On the contralateral side, the bone is gone because of the, positive pressure on the maxillary sinus. So it's extremely difficult for me to look at the 400 or 700 or 800 implants in the world and tell you one is not going to work. But I will tell you one thing, and that's maybe people who are watching this presentation, I don't want to give them unrealistic expectations. Placing short and wide implants is extremely difficult. It's not easy, okay? Because the drill size, look at the drill size. You are drilling into the bone with a drill that has a diameter of maybe 7 millimeters. So if your hands move a little bit, you're done, you destroy the bone. Now, if you use the technologies that are available today, you take a cone beam CT, you might take an intraoral scanner, and then the company you're working with would give you a surgical guide, and you place the implant with a surgical guide. Then, of course, there's no movement. Then it's a piece of cake. You just put the guide. You don't even have to open the flap. It's a flapless surgery. Then the success rates with general practitioners is going to go up. So I'm sure that this presentation is going to be watched more by general practitioners than by specialists like myself. So general practitioners who watch this, I think a good investment in the next 5 to 2 years, maybe earlier, if you are serious with implant dentistry, is to purchase a cone beam CT. And the good news with cone beam CTs is that there are no bad cone beam CT companies in the world. You look at all of them. All of them have great results. Now, one is twice the price of the other one because, I don't know, profit margin, advertising, they're more whatever. But there is not a single cone beam CT company in the world, I think, who doesn't give a decent result. Now, if you're an endodontist, you might want to invest in maybe more expensive machine because you need more attention to detail. But if you're a guy who does implants only, or like, implants and oral surgery, the most affordable cone beam CT will do the job. And then the important thing is that the software of that cone beam CT, the software is probably more important than the field of view. Because if the software is easy to use, then you're going to make less errors. And this presentation, the title is How to Simplify Implant Dentistry. So you choose your cone beam company based on how easy the software is. And if they're working with a company that can give you a very affordable, precise, it has to be both. It has to be affordable, but it has to be precise surgical guide. And now you minimize your errors. So somebody who's just placing implants for 2 weeks will get the same result than me.
Would you consider in the future using, with the same short implants, with the same length, smaller diameter implants to preserve more bone, or the bigger?
Excellent question. Yeah, that's a very good question. I hate empirical answers. I hate people who tell me I think so. No, I'm not a prophet. I'm not, I'm just a doctor who do it. So my answers have to be always backed by science. So the answer I'm going to give you today, I reserve the right not give the same answer 5 years from now.
Absolutely.
But today, I can tell you from the publications I read, and I read a lot, bone implant contact is very important, BIC. Okay. Yeah. Everything being equal, an implant with a diameter of 1.8, which is a mini dental implant, or a diameter of 3, which is a diamond implant, or let's say 3.75 to 4.1, which is a regular size implant, all the way to the 6-7 millimeter diameter implants, they have totally different diameters. So for the same length, they achieve a lot more surface area. That's point number one. The other thing we shouldn't forget, if you do an overdenture type, the emergence profile doesn't matter, right? The emergence profile doesn't matter. It's an overdenture. If you are providing the patient with a fixed partial denture, a crown, a bridge over implants, then the emergence profile is important. So if you have a maxillary molar and you placed a very narrow implant, the discrepancy between the mesial-distal dimension, buccal lingual dimension of the crown, and the diameter of the implant is huge. And as you know, implants have a huge tolerance for occlusal load. But the weakest part of the implant is lateral forces, especially when you go to posterior maxilla. Lateral forces are huge because of the type of mastication humans have. So you put a very large crown on a very short implant, not a short, sorry, a very narrow diameter implant, then you are playing with fire.
Yeah. Like on the long term, the primary stability with a larger surface area, we've seen that it's much more valuable. But with the thinner diameter implants, even though there's less friction and less surface area, but there's more tissue volume and bone volume, that after 20, 30 years from now, we tend to appreciate it more.
Yes.
And we also seen that bone love resonance. The more resonance, the more bone trabecally start to modify itself histologically to hug the implants a little bit better.
Yes.
So I think we're seeing a lot with the different architecture in the future, with the implant being a little bit more submerged, and like the abutment coming out to give you the sense of more diverse chances to manipulate the emergence profile better. What's your thoughts about the mandibular flexure? Like with the mandible, we know that every time we bite down, there's a micro flexure.
Yes.
With the splinting and would you consider that, or would you do it except for the two implants in the middle? How would you balance it?
So I will. So personally, every time I open my mouth, I have to have a scientific article behind what I say. So I'm going to go back to 1985. In 1985, when I was in dental school, the Bible of Implant Dentistry was a book published by Professor Bronemark. And in that book, he was already talking about the mandibular bone being anisotropic. Okay, so the density of the bone, it changes every millimeter. There is a flexural forces in the mandible. So back then, in 85, 86, there was an implant company, doesn't exist anymore, called IMZ from Germany. And they had an element called IME, okay? Intramobile element. And this intramobile element made of a kind of acrylic product dampened the occlusal forces on especially the mandible. Exactly what you say. But we're talking 1985, 1986. So I was reading these publications, and a couple of years later, they decided not to use that intramobile element anymore because, number one, to change it was time consuming. Number two, didn't change anything. So what I mean by that is, really doesn't matter how many implants you place. It does, but not as much as what is the superstructure from. For example, a couple of years ago, the whole world became excited about zirconia, right? So they said, and of course pushed by the industry, industry pushes the products. Oh, you have to only use zirconia, and a lot of doctors they're all on 4 or overdentures, they're not using zirconia, right? So doctors start zirconia for everything. And they start to see a lot of fractures because they want to get the maximum megapascal. And they went from 600 megapascal to 1200 megapascal, and it's too much, So sometimes the trial and error is done in the mouth of the patients. 30 years ago, when you want to make an implant, you first do animal studies, right? Then you do a small series of patients, you observe them for 3-4 years. But then American FDA, Food and Drug Administration, made it extremely easy for any implant company to come and sell their implants in the United States. So you had hundreds of implants copying each other without knowing what they're copying. It was a business gimmick, right? And just to sell it, there was no human trial, 0 patients treated before really the implant, went on the market. Now, in China, believe it or not, they did the reverse recently. The CFDA, the Chinese FDA, wants clinical trials on implants because they're implanted in the body, is orthopedic, and they're from class 2. In the United States, there are class 2. They went to class 3. So it's a lot more difficult now in China to sell a new implant without clinical trial. Why? Because there were a lot of problems. But in the United States today, if you just show that your implant is made of titanium, that you have the proper sterilization, that the FDA can come and look at the factory, You don't have to show one single treated case before you put your products on the market. So today, our guinea pigs for implants, bone grafts, you just name it, is what? It's patients. So the problem with that is that companies, when they do research, they have you sign a non-disclosure agreement, which happened to me 20 years ago when I was doing my PhD. And I tested a lot of biomaterials sponsored by bone graft companies. One of these products was the worst product in my animal studies. As of today, 20 years later, I still cannot publish those bad results because they prevented me from publishing. And very large implant companies in the world that dominate the market, right? 20 years ago, they told us we cannot use bone level implants. We have to use tissue level implants. I'm talking, for example, Straumann, right? And I told Straumann, I was a heavy Straumann user, that we need bone level implants for cosmetic and a lot of other reasons. 20 years down the road, they come with a brand new implant, which is only 40 years old, which is Bronnemark's bone level implant. And 20 years ago, they said, never buy an implant that's not made in Switzerland because it's not going to work. It should be Straumann. Until they bought Neos from Brazil. Neodent. And now they sell Neodent. So the same company who said never use another inferior product, now they're buying. So never ever listen to implant companies, bone graft companies, industry, because they have a vested interest in selling their products. You better have to listen to people like me who are UCLA professors, and we don't believe in a brand. We believe in concepts. The good news is that all of these brands work. So the knowledge and experience of the surgeon and the restorative dentist, and a lot of time, hopefully in the future, is going to be the same person. That's why I published that article back in 2001, 19 years ago, because I wrote that I think 95% of implants in the world should be placed by general practitioners. That's the logical thing. And specialists should do more challenging cases. Like today, I showed you a couple of challenging cases where I had to put soft tissue graft, hard tissue graft. I need to use my talent as a periodontist. I did a frenectomy. I did a lot of things. But it's not easy for a general dentist to suddenly learn to do all these techniques for one patient. Well, you have one patient out of 100 that's like this. That's 1 out of 100 patient you refer out.
Yeah. You mentioned something about the implants that are hard enough, like the zirconia implants and the fracturing part.
Yes.
And yet with the small implants, we don't want them to be small enough that they're malleable.
Yes.
And we need this balance. Yet at the same time, we need this little, not welding, but a little adaptation between the abutment and the implant, the pumping.
Yes.
Hold on, Doc.
Sorry.
Doc, we lost you there for a minute. Go ahead and repose the question, please.
I'm asking about with the hard implants.
Yes.
That we do not want them to fracture, yet at the same time, we don't want them to be thin enough to be malleable, and at the same time, we want the connection between the abutment and the implant to have some kind of adaptation.
Yes.
That decreases the micro movement as much as possible. When after all what you've seen for the decades of your experience in implants, when you lay backward and think, what do you think the future is going to be in the implant designs mostly, and what do you think our future is going to be like?
It's an extremely good question. You know, number one, I love competition between implant companies and bone graft companies and community, because we're not shareholders of these companies. We can't care for the profit margin.
Yeah.
We want them to compete to bring us the best products at the lowest possible price, right? That's what we want to do. Especially if you're in a country that people have a lower income, you want to offer them implants as an option, right? Not everybody in the world lives in Newport Beach and has a lot of money, right? Most of the population of the world doesn't have a lot of money. So I would say the first things I want to distinguish in what you said, there's a big difference between using zirconia for prosthetic purposes, which is the crown and bridge, and for implants. Zirconia implants, to my humble knowledge, and I use the word humble, have not had enough long-term studies.
Absolutely.
Not long-term. And most of the studies are sponsored by the companies who make them. So if there was a study out there that was very bad, you will never see that publication, because they will bury that publication because they signed non-disclosure. When it comes to the diameter of the implants, I want to make something very clear. The mini dental implants with a diameter of 1.8 to, let's say, 2.2, 2.4, the abutment and the implant is one piece. It's a one-piece implant. There is no problem with abutment. And I know doctors who sell these implants and sell thousands of them, and they go out there and say, oh, you can do everything with them. No, you cannot do everything with them. There's no such thing, but they want to sell. They say, can we do a crown and bridge? They say, you can. What are the publications? They're not. Okay, but for the reasons I told you. And you have to be careful about peer-reviewed publications and just the publication. You know, you can publish everything on internet. You can publish everything on any dental. That dental economics is a publication, but it's not a peer-reviewed scientific publication. So the quality of the publications and the number of patients treated, and most importantly, are they sponsored by the implant company? Yes or no? If they are highly sponsored, you better believe that they only show good results. So I think, to answer your question definitively, because Dr. Shah told us we have only 3 minutes left, I love the fact that today you can go and buy mini dental implants, regular diameter implants, and you can also buy wide diameter implants. I like this. The problem is that your staff might suffer because you have an inventory of implants. The surgical instruments are different. Now implant companies, to sell more screwdrivers, they make sure the screwdrivers don't match other companies. But the screwdriver is very expensive. They try to make sure that their torque wrench doesn't match other screwdrivers. So if you're buying 3 different implant brands to have, mini implants, regular size, and large diameter short implants, then you have to think about your staff. You're a doctor. Doctors have no problem using mini implants because we're doctors, But our poor staff, they didn't go to dental school.
Yes.
They're going to be confused if you have to place orders, diameters, keep your stock. So it's a balance between you wanting to use different implants, companies. And the other thing is that most of the smaller implant companies are being bought by the bigger companies because they want to destroy them. They want to get their market share. So if you have an implant placed 20 years ago by a company that doesn't exist, and there's a fracture of the abutment, an implant is doing fantastically well, and you manage to remove the abutment, where do you order the abutment? You can't.
No.
Now you have to remove the implant, which is a catastrophe because you can't untorque the implant. You have to use a trephine and go and get the implant with the neighboring bone. So when you get to my level of experience, you have to take into account so many different things, which is not only the diameter of the implant. So sometimes doctors say, I just want one brand, but then you are adapting the bone to the size of your implant.
Yep.
You are not adapting the implant to the available bone.
Exactly.
So the patient is going to lose because you're going to put a lot of bone grafts because you don't have, narrow diameter implants.
Doctor, you've been underlying the importance and the value of personalizing per patient rather than just standardizing everything. We're doctors. We need to personalize. We cannot just generalize and generalize and generalize. Thank you very much. It's an honor.
Thank you.
I loved your answers and very
Wow,
thorough.
that was very exciting, Doctor. Thank you for all of the different aspects of implantology that you brought to the table. And Dr. Atala, thank you for hosting the session. We are going to continue this path. If you guys have questions for Dr. Zahedi, he has advised you how you can get a hold of him via email. We'll put that in the comments on the section below. Dr. Zahedi, if you had one final message for our peers, what would that final message be in consideration that there's such a grand need for more and more implantologists in the world?
My only message and final message is try to support people like yourself, Dr. Shah, Global, Interdisciplinary Summit, because I know very few doctors in the last 30 years, like you, Dr. Shah, who are pushing the envelope of education. And I know you're like me. You're not sold to any implant company, any implant brand. If anything, you're only a patient advocate. And I know you by heart. So I think we need more doctors who create organizations like this who are not sponsored by one implant company.
Yes.
And that's the way to go, because every time you organize a conference by an implant company, they're going to try to push their products. And you have done always the opposite. Every time I went to one of your conferences and you organize a lot of them, I see people with completely contradictory opinions challenging each other.
Yes.
And I think this challenge of ideas in the, I've seen some of the presenters' Facebook videos that you post. And I love the fact that they so interesting even for me. 30 years I was learning by going on FaceTime for your organization. You have a lot of videos posted, and there were some doctors who were 20 years younger than me. And I said, wow, I learned the doctor is 20 years, he could be my student, and I'm learning. So the newcomers, younger doctors, also I want them to have a lot to say, because I have a lot of experience and knowledge. But I think the younger doctors have to have a place and passion and show what they.
That is wonderful. Thank you for being an educator and a friend of the community and an innovator and many, many other things, and a family man, and all the good things that we ought to be doing as clinicians and practitioners. Thank you so much, gentlemen. It was an honor to have you guys on the 38th day of the Dentistry's Olympics of 2020. Yes. And by next Sunday, that's right, by next Sunday, we will conclude this massive operation, and hopefully we'll get back to our lives post-COVID, the new norm. Thank you.
Dr.
Thank you,
Zahedi,
Dr.
it was a pleasure.
Bye-bye, doctors.
Pleasure.
Goodbye, doctors.
Bye-bye.